Could we start?
Yes, we can go ahead and get started.
Yeah, okay.
I'll just good evening from India and good morning, good afternoon from other parts of the world. And we are so happy to have you here. After a short break, we are starting our online sessions. And it's a great privilege and honor to have been a part of this global health research and innovation working group. I'll be finishing my term this year, and Caitlin will tell you about the coming elections. But it's been a great honor to be a part of this group, and especially thanks to Caitlin, who's been a great support. And we were very young. We started like as babies. Now we come to probably teens, and we have had the privilege of having 3 sessions, big sessions in each of the SIOP. And we grew fast. We have one of the largest WhatsApp groups, a very active WhatsApp group. So I will miss this group, but we have to move on. New fresh faces, new leadership with great newer ideas. So without any further delay, I would especially like to thank Sagir for the he's the one who got me into this, and also the SIOP team, Suzanne, Casey, Kathy, and Guillermo for this opportunity. So I won't delay further. I'll hand over to my colleague, Caitlin. She has a few slides about the group and the upcoming SIOP conference. Over to you, Caitlin.
Thank you, Venkat. So just to get us started, what we'll do is I'll have Venkat introduce the first speaker, and then when Dr. Scott is wrapped up, I'll introduce Dr. Garcia. And then once they're both finished, I'll talk about the process for voting, and then go over what our session for SIOP is going to be later. So very exciting session today.
So Dr. Scott is a legend. He's a very liked and lovable pediatric oncologist in this part of the world. He's an excellent speaker. He is also known as a great author. He has a textbook of pediatric called Pediatrics, Tricks, which is famous among undergraduate medical school students. He does a lot of charity work, and he's a mentor to many of us. He is one of the co-founders of our local state pediatric oncology group, which is called the Tamil Nadu Pondicherry Pediatric Oncology Group. And he has a lot of experience in palliative care. He's done a lot of research in palliative care. So over to you, Dr. Scott, for your talk. I'll be sharing his slides.
Thank you, Venkat.
Are the slides visible?
Yes. You can go to the next slide. Thank you all for the opportunity and good evening. So I'm starting with a question as a reality for myself, and you all can answer yourself that while we are in a busy clinical pediatric oncology work with routine rounds, with procedures being done by a resident and you are supervising, there are some calls from OPD, and there is a transplant patient who is on a septic shock, and you have to write some chemotherapy ordering. And there are some families waiting for the counseling, and you are supposed to take an undergraduate or a postgraduate class today with some 2 o'clock administrative meeting. And you have a research committee who is going to meet at 3 o'clock. How comfortable are you to receive a child with metastatic Ewing sarcoma, with a fungating mass in the thigh, and with pulmonary mets, with hypoxemia, who has come for a comfort care? How many of you will be very confident to give an admission slip and call your pediatric palliative care team to start integrating with your pediatric oncology work? This is a question for me. I asked many years before. Very, very difficult situation. Next slide, please. So many years, like I started my pediatric residency in 1995 in a very topmost Christian Medical College. It's a very topmost hospital in India. And we used to see acute leukemia like plenty. From day 1 onwards as a pediatric resident, we are trained to do bone marrow, intrathecal lumbar puncture, writing chemotherapy orders and everything. But from that time and for many years, my perception. So today we can answer this question. I asked 10 to 15 people yesterday who are trained under me, some students and from northern part of India, some of my fellows who are in Philippines, like what is their perception on palliative care integration, or when do they call? Exactly what I thought many years before, everybody answered that palliative care, pediatric oncologists consider when curative options are no longer available, mostly at the time of relapse or refractory disease or doing end-of-life care. And they also commented that there are a lot of resistance from the family in a developing country with unrealistic expectations for cure. And if there is a pediatric palliative care team outside the hospital, like an NGO-run volunteer doctors with the hospice or any other new hospital, they are very reluctant to go. And also oncologists felt that their prognosis to commit or to comment on the patient whom are treating, they themselves are very uncertain. One example I will tell you. When there is a relapse to leukemia 20 years before, we call it as incurable. There's no option about transplant. Today, post-transplant, we are trying for CAR T cell. So when do we call it as no more curative option? Is always a doubt. It differs from patient to patient, hospital to hospital, according to the financial status and many things. And many of the pediatric oncologists feel it is a burden to take care of a palliative care patient, especially in end-of-life care, when the routine hospital work is very hectic. But most important thing is, if there is a post-autologous transplant neuroblastoma child with proptosis, post-transplant relapse with only comfort care, if they are admitted in the ward with the patient shouting and screaming with pain, and there is a new patient with neuroblastoma admitted, there will be a lot of social issues. That's what pediatric oncologists think. Next slide, please. So my challenges, or anybody's challenges, access to the pediatric palliative care itself is a challenge. One example I will tell you, today in my city, if there is a child with bone marrow transplant comes from North India, they have some options, about 7 or 8 hospitals. They can choose one from government to trust or corporate or medical college institution. But if there is a need for a pediatric palliative care support exclusively, it will be very difficult to select. One more example is, for BMT, our state government supports Indian money is 17 lakhs. It works out almost, I think it's $22,500 for a transplant. But if there is a child with retinoblastoma, metastatic, crying of pain, there is no government support to call an ambulance to deliver a morphine with just a nurse, which may cost around 1,000 rupees, probably $20. So the support system, it's not there for a pediatric palliative care. There is a reality now. Next slide. So this one example, I got a WhatsApp message from the mother. All the messages which I posted, I've got permission from the parents. So this is the mother who is asking. This is the mother of a child who died of Ewing sarcoma. She had a contact from a family, and she is saying a parent of a child in palliation. So they've accepted. Poor family, running from pillar to post. Many hospitals turning them away, saying that it is waste of time. And some hospitals are refusing because they could not pay. The last line is very important, but the child is crying of pain. We stand helpless so many times at this situation. Next slide. So one challenge I told, access itself is challenge. Why access is challenge is, for me, myself, who are trained in a very good institutions for pediatric residency, we hardly any training we had for palliative care, either in undergraduate or postgraduate. So obviously, if the training is lacking, this is what will happen. This is a child's father, the child is an adolescent boy who had relapsed RMS, long story, but only 2 points the father had to tell me, next slide, that whole of his whole journey, he could not forget 2 statements made by a resident. The child has got a stage 4 rhabdomyosarcoma. Nothing could be done. You shouldn't torture him. When he was asking again and again, the way I irritate, blaming anybody, but have we effort, care, and a communication? Next slide. So we cannot blame him unless we train properly. That statement is from a textbook of Pediatric Palliative Care. Underlying statement says, at worst, families encounters with the healthcare system, we leave them with painful memories of their child's unnecessary suffering, bitter recollections of careless and wounding words. This is the one I think we should teach everybody in a developing country. It won't cost anything. That silence is the best answer. Listening is the best answer. If you look at listen and silent, both are same spelling. Every student can be told, if there is a suffering parents with the dying child, just listen to them if you have time. Otherwise, at least call a senior and hand over to them. Next slide, please. Okay, this we proved by a study among the pediatric postgraduates, almost representing from many universities from southern part of India, and we published in a good index journal that 88% of the pediatric postgraduates have never heard about palliative care. Next slide. So I consider the 3 steps of education, that is MBBS, undergraduate, then pediatric residency, and pediatric hemato-oncology fellowship. In this 3 trimester or 3 stages, most of us are unheard about palliative care concept. Maximum we could have heard during our fellowship only. So taking care of the 3rd trimester alone, it's not correct. We are actually unbooked case in terms of 1st and 2nd trimester. Next line. Next slide. So this is another pediatric palliative care book says, the patients receiving care from clinicians who have good communication skills and relational abilities report great satisfaction with care, improved understanding and enhanced coping. This is in 1997, and I strongly believe this statement. Next slide. So this is again a representation of the no training. One of my colleagues from the next state like Kerala, she is asking, she has a very good pediatric palliative care support. Now she is transferring a care to a hometown. Is there any pediatrician who's trained in palliative care? Answer is very simple, no. There's no pediatricians will take care of a pediatric palliative care in their busy OPD. Next slide. So basically, to reduce the hospital burden, the home care and home-based care to be started means pediatricians in the residency should be trained. Next, we train ourselves for the pediatric palliative care for the pediatric oncology patients. Next slide. So my challenge, so I have explained the challenge to access, the challenge of support from the government, and the challenge of training program. My challenge is symptom management. See, we are very confident. If you conduct any exam in pediatric oncology, you will be asked about febrile neutropenia, tumor lysis syndrome, mediastinal mass. Anybody will be very confident. But when you come to the symptom management, like the pain or death delirium, death rattle, how many of our pediatric oncology trainees will be very confident to write an essay or a child mock case at least to discuss about death delirium? Is a question mark. Next slide. So when I had a patient who was referred to me after a relapsed neuroblastoma with spinal metastasis with severe pain, the parents were actually exploring still about immunotherapy, MIBG. All that they had is an Ultraset tablet, but the child was breaking his spine And 7 days in the family, nobody slept. This is what the statement. And they were putting hot water on the painful side, a simple morphine and a palliative radiation. The family texted me saying that 7 to 10 days later, everybody slept for 12 hours from 8 o'clock in the night to 8 o'clock in the morning. Child succumbed to the disease. Next slide. But the relief of the pain, in my perception, I have worked in Australia for 4 years in Adelaide, had a wonderful pediatric palliative care team there. My confidence, I make a perception that pain management is very inadequate in my level also. Although, next slide, please. Although I was trained in US for a short observership, very good team, and many of you would have seen this team in Minneapolis, that the pain management with that expertise also, I am still not very confident. Next slide. So without any training, how do we get pediatric pain specialists in every hospital? Or how do we become pediatric pain specialists? With the two difficulties we have, including my hospital, the accessibility to opioid, severe, significant restrictions of legal issues. This is still a nightmare. Next slide. Many of us think that morphine should be given only to the terminally ill children. Now coming to one more challenge. See, things have totally changed because of the media, mobile phone, access to net. Yesterday also, one mother was asking me, JMML, transplant, but she was showing a Google statement. This drug is introduced, and this is showing some sort of Google. So the parents' attitude. Next slide. One example I'll tell you. There was a child who had a mixed phenotypic leukemia, induction failure, salvage failure, significant infections. Almost 6 months they were living in hospital, ward or ICU. I tried my level best to focus on comfort care, at least for some home care. And the child prognosis is not uncertain. It was almost like there is no curative option scientifically. Our board has decided. Finally, the child died in PICU. Next slide. But when the comment which the father made or the parents made, they are very clear without any confusion. Some of the families even get offended by the suggestion of palliative care concept or a comfort care concept. They asked me a question, how can we keep the child at home without doing anything? So there is no basic understanding. It is my fault maybe. And they thought they are like feeling of abandonment if we say there's no need for ventilation or PICU. So I cannot tell you by a study, but there are significant proportion of patients are wanting to do something, to go all out in the name of love, or at least on the medical name. Next slide, please. There's one more example. So that solution is, if there are like 10 oncologists in the city, and there's one patient, one young oncologist could not convince them for a comfort care only, there should be a board, and with the discussion, they can give a printout to the consultant, shared decision that the parents probably should shift the goal from curative to the comfort care. Next slide. So this challenge can be overcome unless and until. So if there are 7 consultants, 2 consultants have told comfort care, the third person says, why don't you try this phase 1 trial? There will be a lot of confusion with the parents. So the confusion is not only from the parent side, it will be probably from the medical side also. I'll give you one more example here. A parent of a relapsed ALL called me saying that we are getting treatment in another city. We are giving SDP alternate days. The question mark is for me. They are only on comfort care. They are on palliative care. They do CBC every day without any bleeding, because during the therapy, when they were having low platelets, the doctors were giving SDP. They were still continuing SDP. They want to know SDP can given in the city now here under me with low cost. See, obviously it is not absolutely a correct decision, but we should not criticize anything when we receive a patient. I continued that. Slowly the discussion and the comfort care, and explain to them after they develop the complete trust, how the Australian training given me some idea, discuss about dying very comfortably. But there are a lot of uncomfortable young people to discuss about death. I explained to them, see, your child has got a relapsed ALL and you are not giving chemotherapy and you are focusing on a comfort care. The child can die of leukemia progression, child can die of bleeding, Child can die of infection, many things. You're not treating with antibiotics. Somehow you got an idea, you continue platelet transfusion. But without any bleeding, there is absolutely no sense in checking the platelet count, coming to the hospital, waiting in the lab, waiting in the ward, paying something. Finally, they understood. They went off. 1 month later, they came and met me. Both of the parents were shaved their head. It's almost like an Indian tradition. They were not like crying. They said, we had the best month for 1 month, completely away from the hospital, and had a lot of relatives meeting, beach. And he suddenly developed a opistotonic posturing one day, gasping on the way hospital, he died. And they thanked really for their best time away from the hospital. Next slide. So the advantage of the pediatric oncologist to get trained with the pediatric palliative care, or having one more person with pediatric palliative care inside the unit with integration, you know very clearly when do you give cancer-directed therapy in palliation. Because cancer-directed therapy is not a sin during palliation. Radiation for palliative RT, it's not a wrong thing. So it varies from case-by-case basis. In some cases, you have to give only comfort care, non-cancer-directed therapy. In some cases, a transfusion might help. But who decides that? If there is a pediatric oncologist who was treating a child for 3 years or 4 years, relapsed, and then BMT, and then relapsed, and then suddenly if they hand over to a palliative care person who might be a MD palliative care people who are not completely into oncology, now when will they decide about everything related with cancer-directed therapy? They have to definitely travel in parallel with the pediatric oncologist. But what happens if the pediatric oncologist per se will have the pediatric palliative care knowledge? Next slide. 2 or 3 slides, you can show the pictures. Then I will tell. Next slide. Next slide. Next slide. So why I'm showing that pictures, we may be very depressed, developing country, the 100% curable, most curable retinoblastoma still presents like this. So comfort care here has a role of cancer-directed therapy. The children's quality of life from a fungating, smelly mass dramatically responds with chemotherapy. So I believe that integration is the only solution for pediatric palliative care. In pediatric oncology, see, we are very clear, palliative care is not only terminal care. Okay, palliative care is not only end-of-life care. Palliative care is not only for oncology. But in this talk, I am focusing only on pediatric oncology children needing pediatric palliative care. So your oncology team will hand over to the palliative care team only after the curative options are going to getting run out. But integration means you have a parallel system in the same unit. What does it, how does it help? You do any communication, you do some pain management, but there will be improved communication, enhanced pain and symptom care management. How many of a pediatric oncologist, the child comes with induction, L-asparaginase yesterday on steroids, severe abdominal pain. First, what will they think? Pancreatitis, amylase, lipase. Then only they will pass the exam, or even the day-to-day life they will pass. How many of them think that the pain management of abdominal pain is most important or equally important? There comes the palliative care concept. So anything symptom management comes parallel. We are not like masking. Like pediatric training, we will say, cough, don't give cough suppressant. You may miss a diagnosis. That is understandable. You won't miss a diagnosis if you are parallelly having a knowledge with pediatric oncology and pediatric palliative care. The familiarity with the pediatric palliative care is the most important thing a pediatric oncology patient need to have. So either integration or the same pediatric oncology is the most important. So the home care coordinating, oxygen, prevention of issues like bed sore, and if death occurs, like maximum you'll have 20 to 30% of death overall in India. But 10% maybe in a very well-developed center with a profile of patients who are not having advanced disease. So 10 to 20% of patients will need palliative care. The same 10 to 20 patients only, percentage patients only will need bone marrow transplant also. But the fellowships, number of fellowship we have for BMT, number of funding system available for BMT is not in parallel with palliative care is my point. Next slide. So now the last few slides, I am explaining how we have developed with my personal interest in palliative care, with my own reading and experience. we have developed in our hospital, and few of the other doctors have joined. And some hospitals like Cancer Institute has a well-developed palliative care. I'm talking only about our hospital and our state and our city. So I'm not representing the whole of the India. There are some states which are very well developed. Some NGOs are doing, and we have developed. We have done a national level pediatric palliative care conference last month with very reasonable attendance, and that was probably the first time. Every year we are going to have a national conference on pediatric education. We are having a workshop on developing a curriculum for undergraduate and postgraduates. That is going to happen in this month end. Next slide. So my module of a pediatric palliative and pediatric oncology is there should be a person who does palliative care, either a pediatric oncology consultant or a palliative care consultant who is working in-house, who attend rounds. And 3 types of patients I've divided. One is very, very low risk of death, like standard risk ALL, Hodgkin stage 1, Wilms tumor stage 1. He should be only aware, he or she should be aware of this patient, need not see every day. The second group is the metastatic bone tumor, metastatic brain tumor. Probably they have a high chance for relapse, not like 50 to 60% prognosis. The second group, the pediatric oncologist should lead, but the pediatric palliative care physician should travel along. But the third group, pontine glioma, or the ALL, early relapse with BMT, post-BMT relapse, this is the group, like I say, 20% should be led by a pediatric oncologist with pediatric palliative care expertise or a pediatric palliative care expertise. Next slide. So this is some examples after we integrated pediatric palliative care. A child who has been declared to have only comfort care. Her last wish or one of the wish was to have a beach party and a dinner with our students and the nurses and a movie watching with us. And it gave an excellent professional satisfaction for us, which was probably not possible in a very busy pediatric oncologist center who has not got a palliative care expertise. Next slide. And this is a birthday party of a dying child. This mother is very uneducated, very poor from a nearby village. 1 month later, after the child died, she told me she can remember only 2 things in her life. One is receiving the baby in the labor room. Second time was the last birthday, how happy the child was when everybody sang a birthday song and gave him a ball or a car, which was his most favorite. She can never forget. She has no mobile phone or like a photo taken. It's a photo by her eyes and it is in the brain or in the heart. Next slide. So this is our home care. Next slide. So what we are doing now is in the medical curriculum in our university, we have introduced ATCOM, that is Attitude, Ethics and Communication. We have a once a year regular 1 module about pediatric palliative care for the postgraduates. Our nursing team also is trained and they have a separate curriculum. Our occupational therapy has started a palliative oncology, and me and my colleague consultant have published a textbook on pediatric palliative care. Next slide. So this is a research what we have done in the dying patients' parents. Next slide. So I'm just showing some examples like integrating palliative care is possible in any pediatric oncology center and it's not going to cost anything. But the response from the parents, the 3 slides which I'm showing with the parents' permission, which is very awkward to see the dying children, death of the child with photograph, but it's become a culture now. They are wholeheartedly thanking. First slide, next slide. And this is a father who is saying that may your presence is not possible, just pray for him for the 30th day customs and the rights. Next slide. And this is a mother who was very, very poor family. Father has deserted. All that she wanted is before dying, this mask should disappear. Child should be comfortable after death. This is her wish. She was very happy when the mask got decreased before the child died. And the child's death photo she sent with a voice message to a sister. This from another state. I cannot understand her mother tongue. But when the sister told me, it was like tears in the eyes because she was appreciating the only one point is the eyes were become normal before death. So next slide. So this kind of appreciations. This is a father who has written an email. Many thanks for the help. We just cremated him in the afternoon. And evening 4 o'clock, he's sending a mail. If you want all the medical reports or scan, you take it and use for some other patient who can be cured. And we gather our strength, now we'll come and meet you. These examples I told you because in my 25 years of pediatric oncology, the patients who are supported beyond death or during death or the comfort care, their thanks is much more valuable, and that will give you a much more professional satisfaction. Whatever other things you do, this mails and messages, in my personal opinions, that's what I think. Next slide. So it may be last few slides, 2 minutes I'll finish. So there may be a lot of barriers in policymakers, whole healthcare system. We can blame anything, organization, but individually from the physician, that is the pediatric oncologist, there should be some barriers. One of my school teachers told me, I can never forget that. Instead of blaming the darkness, you light a candle. That's what everybody should think. So you cannot speak to the government and immediately change the system. National Medical Council immediately change the curriculum. Just because you changed, all the pediatricians are going to change. Your organization may not change, but your individually in your unit is under your control. That can be blamed means it is you. Next slide. So my final concept is you do a pediatric palliative care support in your unit and audit this. Next. How often you make a facilitated documentation of the resuscitation preferences? How often you discuss about preferred place of death? I'm telling this is only for the 10% of children who are having only on comfort care. So not talking about to all the children. Or how often you audit and see, like how often you stop that SDP comfortably with the parents, with less invasive diagnostic or therapeutic intervention, fewer elective or emergency hospital admission, never an intensive care admission at time of death, and encourage home death. Next slide. This is what I don't like is palliative care means is like a charity or ashramam, or the transplant center or the PHO center should be a luxurious. We should never think, it's not be just with an NGO and you dump the patient there only for pain relief. The PHO, pediatric hematology, oncology, transplant, and palliation should not be in any way different from each other. Next slide. So what we should do is, the word palliative care is most hated word by the parents, means you should never introduce, you don't need to bother about introducing that word. If you are integrated pediatric palliative care expertise in the oncology, you don't need to introduce them as a palliative care specialist. He or he is an oncologist. Like if you look at the life insurance, if you are getting married, on the day some insurance person comes and says, sir, take a policy, and if your husband dies or wife dies, you will get a huge money. How often do you like that? Obviously, that is correct. You get a huge money. It's a good protection. So you cannot go and tell a patient, when you relapse or during death, we'll take care of you. We don't need to tell that. You just show that when there is a need. Pediatric oncology developed very greatly in developing countries with 80% prognosis. So less than 10% need dying care. You tell them nothing you support care when there is a need. Next slide. So we have done, this is the last. So my concept is integration into the unit or integration into yourself. Like I have integrated palliative care inside me. I have not stopped doing pediatric oncology or hematology, or like I am supporting PMT in my unit, although I'm not a trained PMT physician. So 4 consultants of us now, and 1 consultant is trained with pediatric palliative care. So I am introducing a concept from India. There's a Hindu god, his Lord Shiva. This is a god of destruction actually. And he has devoted, or 50% of his body he has shared with his partner for women. So that is the male 50%, female 50%. So 50% may not be needed for palliative care for all pediatric oncologists. Even 10%, 15% is okay. But 25% of a pediatric palliative care unit should have this. Next slide. So pediatricians are very trained in receiving a baby, resuscitation, National Resuscitation Program, UPGAR. But we should develop confidence to face the death also. Human life is palliation. This is what they taught me in US during the palliative care. First statement, human life has no cure. Everybody has to die. But how comfortable we make them while they are dying with dignity. That is what is important. Thank you.
Thank you, Dr. Scott, for this wonderful talk, sharing your experiences, and very vital to integrate palliative care in our setting. As you say, many of us keep palliative care at the at the bottom of our least priority. But you have, I have to say, in India, got this reawakening, I would say, in getting palliative care into our clinics, into our day-to-day work, and best wishes for continuing this great work. Thanks a lot. Hand it over to Kathleen, and probably can have questions at the end. Kathleen, do you want to introduce Ximena?
Yeah, that would be perfect. Thank you again, Dr. Scott. That was a great presentation. I'm super pleased to be able to introduce Dr. Garcia. So Ximena was a pediatrician. She's from Colombia. She got a master's degree in pediatric palliative care in Spain, and then also trained at Harvard through their medical school palliative care and education and practice. She founded one of the few pediatric palliative care programs in Colombia, and also received a My Child Matters grant in support of this program. She joined St. Jude Global as the program coordinator for the Global Palliative Care Program, and it's been a complete delight working with her over the last several years, both through palliative care opportunities and through shared interest in implementation science. And so I'm very pleased to be able to introduce her today, and I'll turn the slide sharing over to you.
Thank you, Kaylin, and thank you everyone for inviting me to share our experience with all of you. And thank you, Dr. Scott, for such a brilliant presentation, beautiful description of what is the importance of palliative care. So I would like to start with a reflection. And I imagine that many of you that are here at some point of your career have been able to support and care for a child that is at the end of life and accompany their family through this, I will say, devastating process. And I would like you to feel how it feels, because in my experience, being able to support and care for so many families that had been going through this experience, it had been very painful. I am a mother of two beautiful girls, and I can barely imagine what is going through this devastating loss. So I wanted to ask you if you could do something to help those bereaved parents. Will you do it? So that is exactly what we did in Fundación Valle del Lili in my country, Colombia. And that's why I'm here today to describe the implementation of the outcomes of the implementation of the end of life and bereaved program in our hospital back in Colombia. So before we move to methods and results, let's review a little bit what it says the literature about the death of a child. And actually, it's described as the most devastating event that a parent can